Our topic for today is pediatric malnutrition, and we'll start with a definition. Malnutrition is a chronic state of nutrition due to inadequate food intake. It may be caloric or protein or combined caloric and protein, and this condition is very specific for small children, infants and small children, younger than 5 years. Of course, we can see this situation and this status in older patients, in children, in teenagers. It's a big problem now for adult persons, for elderly people, especially chronically ill people. But we will discuss only pediatric malnutrition. Malnutrition we can divide for three big groups. The first group is pediatric undernutrition, and pediatric undernutrition includes wasting, stunting, marasmus, and kwashiorkor. And marasmus and kwashiorkor, it's terms we usually use in patients with protein energy deficiency, and we can find it in the International Disease Classificator. Another group includes overnutrition, and this is a big problem now too. But we will not discuss the overweight and obesity in this lecture. We will have another specific lecture when we will tell about this problem. And the third group is macronutrient deficiency. In some cases, in most cases, it can be with undernutrition. An undernourished patient usually demonstrates vitamin and microelements deficiency. But patients with obesity and overweight sometimes have the same. They've got a macronutrient deficiency. And in some cases, and in developed countries, in most cases, we can see this isolated macronutrient deficiency. When we are talking about stunting, we have to remember that stunting is a low height for age. So z-score for this uh, mark is less than -2. Wasting, it's a weight lower for height, and z-score weight for height less than -2. And usually when we are talking about wasting, it's maybe chronic starvation as a stunting, but the acute starvation usually appear with wasting. Overweight means that patients have got a BMI score for age, z-score BMI for age more than 1.5, and obesity BMI more than 2. When we are talking about another classification, we can classify it under nutrition due to uh, duration of this situation. And acute usually it's uh, less than 3 months, and chronic more than 3 months. And again, acute usually it's wasting, and stunting it's chronic situation. When we will see the latest statistic data, when we can find in the World Health Organization's website, you will see some good situation in 2019 when we've seen the decreasing uh, morbidity, the decreasing number of stunted patients around the world, and it's very good. And of course, we can see increasing the number of patients with obesity. But don't forget about the Corona-19 pandemic, and all the experts and researchers declared that after that pandemic situation, we will have increasing number of children. And of course, the widespreading of this situation, of this status, is not equal in different countries. If we will see for this map, again, it's a 2019, it's official data, you can see the countries with quite higher, more than 30% of population have got the stunting. We are talking about pediatric population. And you can see in India, in Africa, quite higher level, quite higher rates. And globally, you see some improvement, but it's 2019. If we are talking about the regions, you can see most of regions demonstrated decreasing, but Western Central Africa demonstrated increasing this number of patients. Wasting. We can see again quite the same colors. So again, we can see more than 15% in India and Africa, 10-13 in Asia. So it's quite common. And you see, we've got improvement again. Not so rapid, but quite visible. When we will tell about India, you can see in India different rate of the stunting in different states, and you can find the information in the latest information, big statistical research when authors just make analyzed the widespreading of the wasting and stunting in different states of India from 2000 to 2017, and you can see a very good improvement. You can see the change of color, so the rate of this situation with this disease stunting decreased. And the same we can see for wasting, but it still be quite higher, and you have to work very hard to change this situation. And it is not so easy, and you can see in this map, it was published in the very famous medical magazine Lancet, and you can see the disability adjusted life years per 100,000 patient, and you can see the leaders of this disability due to stunting. It's Rajasthan, Uttar Pradesh, Bihar, and Assam in India. So you've got some places in which you have to do something with this patient. And of course, it's a very severe situation now in so nice country like Yemen, and you can see a lot of children have got a severe acute malnutrition, and this is the latest thing from 2021 February. You see that half of children younger 5 years in Yemen have got a malnutrition, different stage of malnutrition, and you can see this severest malnutrition in Yemenish children. Yes, in Sana hospital. In Iraq, 1 of every 5 children stunted. Unfortunately, we have no the latest statistical data, but I think you can see it in your country. You can see this situation too. And globally, increasing level of obesity, we spoke about it. So the most dangerous for children for pediatric malnutrition countries still be Africa and Asia. Malnutrition is a very severe situation in which the mortality in some diseases in children dramatically increasing. You can see the diarrhea, upper respiratory tract infection, measles, and even malaria became mortal for children with malnutrition. What is the risk factor for pediatric malnutrition? It's a level of education, of course. It's a social economical status of the families. It's a difference feeding and weaning practices. Chronic infection like tuberculosis, HIV, it's a severe chronic disease like cancer. Of course, it's age because the youngest children have got more severe cases of malnutrition. Of course, it's sex. In some nations and some countries, girls unfortunately in a risk group for the malnutrition. Security status and climate, weather, location. It's very close to the socially economical status, because in regions with poor environment, we can see the high rate of pediatric malnutrition. And of course, the infection. Poor hygiene leads the highest rate of infection in pediatric population. And infection and malnutrition usually accompany each other. And in patients with the malnutrition, we can see low immunity, and due to that, increasing severity of infection, and severe prolonged infection leads low appetite and low food intake, which of course provoke decreasing or increasing severity of the malnutrition. If we will see the pathogenesis, in the first glance it's very easy to understand, because we can see the reduced dietary intake and maybe absorption, and it's not enough for patient life needs, and we can see the malnutrition. If we will just classify it or divide all the causes of malnutrition for groups, maybe it will be easy for you to remember it. So we can divide it for following groups. First of all, inadequate intake. When we can see this situation, of course, when the patient or patient's family have not enough food, starvation due to poverty, food insecurity, it's maybe inability to consume food, drink, poor oral skills in patients with severe neurological disease, dysphagia due to some abnormalities of GIT. It's maybe some oral aversion like force feeding or pain due to stomatitis, for example. It's maybe vomiting or reflux or regurgitation, and it's maybe maternal neglect and maternal depression when mother just don't want to feed their babies. Inability to digest or absorb in nutrients. When we can see this situation, diarrhea, infection or non-infectional diarrhea can lead this malabsorption. Malabsorption syndrome due to chronic hereditary inborn disease, for example, celiac disease, cystic fibrosis, chronic inflammation of gastrointestinal tract, or short gut syndrome. Inability to fully metabolize nutrients. In case we've got enough food, the food can be absorbed, but in case of metabolic disease, in which cells can't take these nutrients, we can see the malnutrition. And it's quite a rare disease. We will discuss it in our practical class, like mitochondrial diseases, storage diseases. So in this patient, we can see malnutrition. It's usually stunting. It is short stature, and it's due to this inability to take the nutrients from the bloodstream. And the last one, increased requirements. Why can we see this? Increased breathing. What is it? It's a respiratory distress syndrome. In this situation, organs work so hard, need more nutrients. Increased cardiac work, heart failure, congenital heart abnormalities, cardiomyopathy. This patient again will demonstrate the low nutrition. Chronic infections. Chronic infection, we discuss about these chronic infections. It's tuberculosis, it's HIV, it's hepatitis, it's maybe another diseases, not infectional, for example, malignancy. Patients with cancer usually have got a cachexia in some end stages, because tumors need a lot of energy, so they use all the energy from the body. And endocrine disorders. The classic example is thyrotoxicosis. Pathogenesis. When we got a patient with inadequate calorie intake, the organism start to have energy deficiency, and main energy substrate is glucose. So hypoglycemia leads the activation of the compensation processes, and in case of activation of these processes we can see the low insulin secretion, and additionally for this we can see the low amino acid level, so insulin can't be produced in a proper amount. So, without insulin, the energy can't be stored. Severe lack of calorie and protein and energy deficiency activates the gluconeogenesis, in which patients start to use the free fatty acids and proteins to synthesize new glucose molecules, and due to this, to compensate this low glucose intake. Decrease in enzymes and protein synthesis due to this gluconeogenesis, because enzymes and transport proteins is a small protein, and organism prefer to use these proteins at the beginning, leads decreased metabolic processes intensity, so we've got the low digestion of food, low absorption because the gastrointestinal enzymes decreased. We've got the low rate of transport in bloodstream. Nutrients can't be transported very fast. So we can see energy deficiency and protein synthesis decreasing. Of course, immune system can't produce good quality of good quality proteins, antibodies, can't activate the T cells, and we can see immunodeficiency and infections. And infections usually lead some dysbiosis or impaired gut microbiota, and organisms stop to receive some vitamins, which usually our microbiome can synthesize, and can't protect the mucus of the intestine. Due to this, we can see enteropathy and again immune deficiency. In case of marasmus, we can see adequate the equal protein and calorie or energy deficiency. And due to this deficiency, the adrenal cortex activates, and we can see increasing of the cortisol and another cortex hormone. But for us, it's very important to remember about the cortisol level. So cortisol activates gluconeogenesis. So, due to this gluconeogenesis in plasma, we can see quite good level of amino acids. Not protein, but amino acids is quite good. So, organism can create very necessary proteins in some situation, in some condition, in some time. Not long time, not long time. In the starvation, in prolonged starvation, in chronic starvation, we will see some problems with the protein synthesis. But at the beginning, we can see quite adequate level of the plasma proteins. And we can see the inhibition of the growth hormone, and we can see the growth retardation. Using of the muscles proteins will lead the low muscle mass, and we can see it in patient. And of course, in this situation, we can't see the severe non-alcoholic fatty liver disease, because the fatty acid uh, don't storage in the hepatocytes because they use to the gluconeogenesis. In case of kwashiorkor, in which we can see another clinical picture, and usually Russian students who never see this patient never can recognize malnutrition in so little bit obese patient for the first glance. Why it's happened? Because it's deficiency of protein intake first of all, and the adrenal cortex don't react in the good manner, so gluconeogenesis can't be activated, and the growth hormone increasing, and it leads the increase in the free fatty acid of the in the blood. But gluconeogenesis don't activate and doesn't activate, and organism can't use this free fatty acid. It leads the non-alcoholic fatty liver disease or storage fatty acid in hepatocytes, and we can see extremely low level of amino acids and protein in plasma, which leads to low oncotic pressure and severe edema. And in all the patients with malnutrition, we can see the problems in all the system and organs. It's a multi-system disease. It's a central nervous system. We can see depression and apathy and letharginess. We can see low immunity. We can see renal dysfunction, hypothermia. We can see impaired gut microbiota and immunity, anorexia, and all the organs usually suffering in case of low energy. If we will compare the clinical signs of the marasmus and kwashiorkor, you can see in marasmus, we can see the low fat, we can see no edema in first two stages, mild and moderate. In severe, we can see localized edema. In case of kwashiorkor, we can see edema of different grade. Usually it's moderate and severe, and we can see more visible skin problems like discoloration, like atrophic macules, and we can see the discoloration of hair. So the main differences is edema, discoloration of skin, and problems with the nails and hairs. And the marasmus, you can see it's a classical picture of malnutrition. We discussed and we seen the map with the rate of malnutrition in different country, and you can see that the, in developed country quite low, but all the country have got a patient with malnutrition, and of course chronic undernutrition usually due to chronic disease. And in first place in this rating is the multiply condition, combined diseases, and next neurologic diseases. Neurologic patient with this perinatal brain injury, with cerebral palsy, usually demonstrate severe malnutrition. Infection disease, especially chronic infection, cystic fibrosis, cardiovascular disease with hypoxia, oncological disease, the leader in the causes of the malnutrition in developed countries. What should we do if we've got the patient with the malnutrition? We have to very careful, extremely careful to take the dietary history and patient history to find chronic diseases and maybe congenital abnormalities. Of course, we can do the very accurate measurements, anthropometric measurements, weight, height, mild, mid, upper arm circumference. We can check the chest and head circumferences, and of course we can check the skin fold size if we can, of course. And laboratory test. Complete blood count to find the signs of the infection and anemia, blood glucose level, septic screening. What does it mean, septic screening? It's CRP, it's of course CBC, it's a blood culture and procalcitonin test. Stool and urine analysis to see the signs of the kidneys problem, to see the signs of the pancreatic or intestinal enzymes deficiency, and of course to find the parasites and germs. Electrolytes, which should do it, are calcium, phosphorus, alkaline phosphatase, serum proteins, includes albumins. Of course, we have to check the MAN2 test to check the information about it or to do it, and if we need to do the HIV testing and some specific tests to find the malabsorption syndrome. After the measurement, we have to evaluate our results, and usually we use these curves or charts, growth charts, but to diagnose and to manage the malnutrition, it's not enough because we can't see, even we can, if we use a body mass index, it's a little bit better, but we can't evaluate accurately, we can't evaluate the severity of malnutrition. And severity of malnutrition, due to World Health Organization guideline recommendation, we have to evaluate using the Z-score of body mass index, Z-score of the MUAC, height or weight, so Z-score, and we can't see the Z-score in the growth chart. So to do this, we have used the anthropometric calculator, which you will find in the World Health Organization website, and it's very easy to use this thing. You have to put the date of birth of patient and of course sex. Then you have to put the weight and height results, and you can use the kg or pounds if you want, and the program automatically will calculate Z-score for this patient. And what's a nice thing which we can use and we can see here, it's, I think, especially for medical students, you can see the different color in these windows. The black color, it means, of course, it's very severe situation. Green color, it's quite good. You can see here, but if you will download this program, you can see the some red color, it's like alarm, and yellow color, like be aware. So it's quite useful and very good program, which I really recommend you to use. After the evaluation and after the diagnosis and finding the severity of the malnutrition, we have to decide how can we treat patients. And in case of mild malnutrition, we don't use a specific treatment. We have to recommend to improve the diet, and if the patient have got some diseases, just treat the diseases. In case of moderate malnutrition, of course we have to treat diseases if we find it, but in moderate malnutrition we need to give patients some supplements, supplementary food. World Health Organization, due to their international programs, usually give the countries special ready-to-use supplementary food. It's usually bars, some soybeans-based, or peanuts-based bars, which are rich in protein, micronutrients, and vitamins. And you should add this supplementary food to the patient diet. In case of severe malnutrition, we've got two types of patient, with complications and without complications. In case of patient with severe malnutrition, with quite active, stable, and have no severe diseases, you can use the ready-to-use therapeutic food. In case of severe malnutrition with complication, when patient became really unwell, we have to use a therapeutic milk, and usually this patient should be hospitalized. The detailed uh, guideline about the treatment of patient we will discuss in next part of our lecture.